The topic of my presentation today will be neuroplasticity of ADHD. And to begin with, I will take you through a little bit of the history of neuroplasticity, how we discovered that neuroplasticity exists in the brain, and then take you through the types of neuroplasticity, mechanisms of neuroplasticity, and then give you an overview of what in ADHD do we know about neuroplasticity and how we can help families who have individuals with ASD, whether it is children, adolescents or adults, through neuroplasticity. How can we help them, and using these mechanisms, how can we help them get their symptoms in a better place. So we have all heard about the double hit hypothesis, that when we are growing right at the fetal stage itself and after birth, through developmental periods of infancy, the child being a toddler, and then early childhood, we know that even though there is genetically mediated human brain growth which is happening, there is also a lot of environmental factors right from conception which keep on influencing the brain, the way the brain develops, and the way we develop as humans, our personality, our ways of behavior and cognition. So until about the 1970s, it was just known that human brain, as soon as it is conceived, as soon as a human is conceived, brain will just increase in size, like how an embryo just grows bigger and bigger. Until the 1970s, it was thought that brain also just follows the same mechanism. As we grow older and older, the brain size grows bigger and bigger. However, in the late 1970s, after many people doing research, what was found was that the prefrontal cortex continues to have structural changes which are going on even during adolescence and early adulthood. And this discovery then led on to a lot of research in the early 90s and the late 90s, where technological advances emerged, like the CT scan, the MRI, the EEG, and all of those things emerged into the mainstream, and because of which people started realizing that it's not only brain development which stops at childhood, but there's not just that, there's also something else that is going on which in turn influences behavior, in turn influences cognition. And very popularly, the 90s is also called as the decade of the brain, because there was a 5-fold increase in research which was related to neuroplasticity, and also there was an increased interest in this topic even in the media and the press as well. What they then found was, like we know that, like all of us are aware that right from 0 till 6 years of age, the brain is growing very rapidly. Most of the development happens between 0 to 24 months. But then after that, up till 6 years of age, there is also brain growth which is happening. And maybe by 6 or 7 years of age, you have about 90 to 95% of brain growth which has happened. But what was also discovered, that each lobe and its particular functions also develop at different ages, and these are influenced by a lot of things around us in the environment, apart from being influenced by our genetics as well. Just as you can see on the slide, the frontal lobe, which contributes to thinking, memory, executive functioning and other complex behaviors, predominantly develops between 3 to 12 years of age. And when you look at parietal lobe, like the important hardcore functions of the brain, like the singing and the talking and memorizing and all of those things which happen, they predominantly happen from birth to 6 years of age. So different areas of brain were found to have different time periods of peak development, or what is also known as the critical period of brain development. Apart from the structural changes which are happening at different parts of the brain, the different lobes of the brain, there is also microscopic change which is happening. Of course, we are familiar with that, but the synapses and the synaptic density changes which are happening are extremely rapid. And as you can see in this picture, right from conception onwards, as it is depicted here till 4 years of age, you can see that there is difference which is seen in different areas of the brain, like how it is shown here in the medial frontal gyrus, the auditory cortex, the visual cortex, all based on whatever input the brain is getting during the period of brain development. So what exactly is neuroplasticity? So then once all this was found, what researchers were curious to understand was the idea that how are we learning all these things? We have cognition, we have behavior, we have speech, language. It's not just because of the increased brain size that we know all of these things, but what exactly is going on in the brain which is helping us learn these things. So of course, there are synaptic activations, there is strengthening of connection, all of this in turn implicating to a particular style of behavior, right? So what exactly is neuroplasticity? So neuroplasticity was basically defined as the ability of a brain to form and recognize synaptic connections, especially in response to learning. So it's a response to learning, it's response to a particular experience, or even for that matter, it's response to injury. So let's say the brain had injury at birth, or had an insult, an inflammatory insult during the period of brain development. All of these things also can influence the ability of the brain to form connections, and connections can keep on changing because of these influences. So then, just to give a glimpse of what exactly happens is that there is neurogenesis. So there are new neurons which are being formed constantly. There are new synapses. So it's not just neurogenesis that new neurons are being born in certain brain regions, but also there are new synapses which are being formed. Apart from this, there's also strengthening of synapses, but there's also weakening of synapses that is going on. So when we say neuroplasticity is occurring, it can be in different ways, like there is changes in the dendritic spine, there is hormonal activity which is going on, microglia activity, neurotransmitter influences, DNA regulation and transcription. So there can be a lot of changes which are going on at the same time. And all of these things can definitely be influenced by some of these factors which are listed here, and especially like Dr. Madhulika just mentioned, in children who have autism, of course there are events which can happen at birth which can influence. There are genetic factors which can result in difficulties. Apart from this, there can also be maternal stress which can contribute. There is stress during the growth period which is going on. There can be diet, medication, influences of medication, influences of experiences basically the child is exposed to during the period of brain development. So in 2008, researchers Klein and Jones basically gave some basic rules about neuroplasticity itself. So I'm just going to give you an overview of those rules, and I'm not going to go into details of this because we can touch this later on when I talk about ADHD. So some of the rules are use it or lose it, right? So there is failure to derive specific brain functions. If there is failure, then it can lead to functional degradation. So let's say you're not you're not driving some particular brain functions, over a period of time we tend to lose it. And if at all we have to enhance this, then you definitely have to drive these brain functions. And of course, the nature of training experience that basically dictates the nature of plasticity has to be very, very specific, and also has to be enough repetitive so that the newer connections are formed very quickly. And like I just mentioned, the intensity or the training intensity, the repetitive intensity also has to be very strong enough so that newer connections happen. Again, time matters. We are all aware of the critical period of brain development when a lot of these things are going on at the same time. So different forms of plasticity occurs at different times during training. So it also depends on age, younger age versus older age, and how it is going to affect neuroplasticity. Salience matters. So training experience must be sufficiently salient to induce plasticity. And like I said, age matters, and there should be transference and interference when we are looking at acquiring behaviors. So neuroplasticity itself can be divided into different types. So one of the important classifications is the developmental neuroplasticity and the experiential neuroplasticity. So developmental neuroplasticity is something that happens through the period of development, which is influenced by the individual's genome, and it is a series of processes which involve cell migration, synapse formation, and other aspects of brain development which occurs in a particular order. So this is basically because of evolution, because of the way we are made, because of the way our genes are made, that developmental neuroplasticity occurs. However, if there is a perturbation during this developmental neuroplasticity, like let us say when the child is still, when the baby is still in the fetal stage, all of these insults can definitely result in abnormal brain development. So developing systems are not necessarily fixed or immutable and are definitely susceptible to differences that reflect severity and a particular point in developmental time. However, experiential neuroplasticity is something that happens following an exogenous stimulation. So we are stimulating the brain, or we are restricting the brain from a particular stimulus, and that in turn results in experiential neuroplasticity. So basically when the baby is growing up, it is a superimposition between the developmental neuroplasticity and the experiential neuroplasticity, which in turn result in the way the brain functions in every single individual. Neuroplasticity can also be classified as structural versus functional neuroplasticity. Like I initially mentioned, there can be an increase in brain size, but as I just mentioned, based on experiential neuroplasticity, there can also be an influence of experience which results in changes in the function of the brain. The way we give input, the output of the brain can also differ accordingly. So in functional neuroplasticity itself, there can be 4 forms. So there can be homologous area adaptation, where a particular cognitive process is defined by a homologous region in a particular hemisphere. There can be cross-modal reassignment, where structures previously devoted to a particular kind of sensory input are now receiving input from a different sensory modality. So there can be cross connections in the brain which are going on. There can be map extension. So there can be enlargement of a functional brain region based on whatever is needed. So like for example, let us say there's a person who's a musician. So there can be expansion of those areas of the brain which are helpful in that person attaining a certain level of expertise. And compensatory masquerade, where there is a novel allocation of a particular cognitive process to perform a task. So all of these things can happen in functional functional plasticity. Again, there can be afferent plasticity versus efferent plasticity, where afferent basically means that there is it is happening at the level of the axons, where there is collateral sprouting which is going on, reformation of the synapses, rerouting of the axons, basically to make sure that we are catching new experiences. Whereas efferent plasticity basically means that in the cortex, if there are abnormal efferent zones, it is accompanied by changes in the terminal territories as well. At the microscopic level also, there can be microglial plasticity versus neuronal plasticity. Like I said, some experiences make us create new neurons and create new synapses, but there are some times when microglia have to come into the picture, have to get into the activity of phagocytosis, so that some neurons are replaced by newer ones, so that we learn new experiences, which in turn can lead to a particular behavioral outcome. Now moving on and slowly transiting to understanding ADHD and experiences from the ADHD population itself. Like I said, there are critical periods for experience dependent plasticity, which are driven by a number of plasticity inhibitors and cellular breaks. I really don't want to go into reading details of all these things, but if you see the picture on the left hand side here, the critical period is the period where there is an onset of sensory experiences, which is triggering the opening of critical periods of window, which in turn is helping us get passive stimulation from the external environment. So because this period is extremely critical, with maturation, the brain sets itself into a particular rhythm where we are learning new behaviors. We have a particular behavioral outcome as an individual ourselves. And many times when there is abnormalities of these micro level issues in the brain, it can result in disorders of plasticity and in turn associated neurodevelopmental disorders, including autism and ADHD. So sensory inputs which the brain receives, like I said, are the rules of plasticity. And when we improve the quality and quantity of sensory inputs during the critical period windows, it definitely improves the behavioral outcome in a particular child. I will come to this particular study by J. Mishra et al., which was published in 2016 in the end. But just to give an overview of it is that when we give sensory input with low signal to noise ratio, it can trigger plasticity in the mature cortex. So what is low signal to noise ratio? I will come to it later on. As we are all aware, in ADHD, there are neuromodulatory systems which are affected, which is the dopaminergic system, the norepinephrine and the cholinergic systems, right? So these in turn, the upregulation increases cortical representation. When there is cholinergic system activation, it in turn helps in the projection of cortical neurons and helps understand complex processes in the frontal lobe and the neocortex. Though there is inter-individual variability of neuromodulator tone, this in turn has known to be represented by cognition. So it is known that those who have higher IQ, those who have better skills, they are known to have better neuromodulatory tone compared to the rest of the population. So what exactly happens in ADHD? So in ADHD, as we are all aware, there is inattention, there is hyperactivity and impulsivity, or there can be a combined presentation with the child having both the symptoms. It can be predominantly inattentive or predominantly hyperactive impulsive presentation, depending upon the various neuromodulatory changes which are happening in the brain, which I just mentioned. Apart from this, we are also aware that children with ADHD can have other psychiatric comorbidities like depression, conduct disorder, opposition defiant disorder and anxiety, especially in the younger age groups. But as they move on to the older ages, they also can have mood disorders and other complex psychiatric disorders. So the core symptoms of ADHD, if we are actually looking at where exactly in the brain are these represented, they basically are represented in the frontal lobe. Predominantly, maybe we can pinpoint selective attention to the dorsal anterior cingulate cortex, the attention problem solving component to the dorsolateral prefrontal cortex, hyperactive symptoms to the prefrontal motor cortex and impulsive symptoms to the orbitofrontal cortex. When you look at studies which have assessed for neuroplasticity training based output in children who have ADHD, these are some of the tests which are used. For example, the first picture here is called as the NBAC test. The first picture is basically representing the motor hyperactivity in the prefrontal cortex. The second picture is representing the impulsivity which is modulated by the orbitofrontal cortex. The third picture is representing selective attention, which is basically assessed by the Stroop task. And the fourth picture is representing attention and problem solving skills, which are tested usually by the NBAC test. I won't really go into the details of what exactly happens in these tests. Maybe if anybody has a question, I can explain it in the chat box later on. Like I said, tonic firing, if you remember, I just used the word neuromodulatory tone. So tonic firing basically means, if you see the first picture here, it is the regular intervals at which the norepinephrine and the dopaminergic neurons in the brain, in the prefrontal cortex in particular, are firing, right? So what happens in ADHD is, because there is a stress factor which is going on, these norepinephrine and dopaminergic neurons run into some kind of a dysfunction, right? So it can cause inattention, problems, concentration difficulty, all of these things resulting from excessive arousal. So this is something which is called as an excessive arousal. So there's something called as an inverted U signaling for the dopaminergic neurons. So if there is a deficient signaling, it can result in difficulties with attention and concentration. But if there is excessive signaling, like how the second picture here is represented, it can result in hyperarousal, in turn resulting in problems of attention and concentration as well. So predominantly because of the critical period of brain development, the experiences which we are going through and the neuroplasticity period of the brain, we can see that most of the symptoms of ADHD are not really visible up till around 3 to 4 years of age, after which the child will start showing difficulties. So in the preschool period, there can be problems of distractibility, unable to sit in the class or unable to follow rules when they are playing with their peers. But as they grow older and reach about 5 to 6 years of age, that is when inattentive symptoms of ADHD become actually noticeable, because that is the age by which we expect the child to start having planning skills, start having the ability to sustain attention for longer periods of time, and also have memory and formation of abstract concepts. So there are some studies which have tried to see how neuroplasticity is induced in children who have ADHD, especially through behavioral training. So when we look at how we treat children who have ADHD, I'm not really going to talk about the pharmacological management of ADHD here, because the topic is neuroplasticity, which is predominantly induced by therapy, the various forms of therapy which is used in ADHD, whether it is behavioral intervention or sensory motor training which is given, somatic therapy for that matter, or cognitive behavioral training. All of these follow the same principle of neuroplasticity in the brain. So I will just talk about some of the important studies which have demonstrated how we can find out that the brain is actually neuroplastic and is helping individuals with ADHD. So as you can see here, EEG is one of the techniques in which we can identify whether the child is the child is improving in the ADHD spectrum. So as you can see here, the left picture is basically the normal brain map, and the second picture you can see that the frontal part of the brain shows excess immature activity in the form of slow theta wave activity. So as we are all aware, frontal lobe basically must have beta activity, but in children who have ADHD, they tend to have theta activity. So there are different modes in which neurofeedback, which is one of the training methods which is used to identify and to train individuals with ADHD. The technique basically uses EEG and fMRI techniques as well. So what basically happens in neurofeedback when we use it as a treatment is, the idea is to lower the frequency of the theta waves which are present in the frontal lobe and train the brain to induce beta waves which were absent in the frontal lobe or which were present in lesser frequency. So the neurofeedback training, while the individual is performing a particular task, gives input to the person so that the child or an adolescent who is undergoing neurofeedback training is aware and knows and is trained to avoid this particular theta activity in the background. So the theta activity is, the child is or the adolescent is learning to suppress the theta activity, avoid distractions, and then focus more so that the beta activity in the frontal lobe is increased. So that is the principle which is used. So there was a clinical trial which was conducted by Monestra et al. In 2002, where they looked at 100 children with ADHD, where one group was given Ritalin, which was the only treatment which was given, and the other group was given Ritalin along with neurofeedback training for a period of 1 year. And what they found was there was significant improvement in behavior when it comes to the group which had both pharmacological as well as neurofeedback training. And what was most fascinating was, apart from improvement in behaviors, there was also sustained improvement in behavior, and the improvement was maintained for more than a few weeks or months of time. Though in this particular paper they have only mentioned 1 week post treatment, but there are also other papers which have looked at long-term consequences of neurofeedback treatment and how they can induce brain changes. There have also been studies where they have shown that even corpus callosum, for that matter, can have neuroplasticity, which in turn can lead to significant structural changes in the brain. So neuroplasticity is not only inducing behavioral changes, but also in areas such as the corpus callosum, there have been studies which have found structural changes in the brain as well. Apart from this, there was a systematic review which was published in 2020, where they looked at about 28 studies of 28 neuroimaging studies which have employed techniques of identifying neuroplasticity, which was based on experience training. So they categorized the papers into 3 different groups. One was the non-clinical neurotypical group, one was the clinical developmental group, in which ADHD was one of the component, and the clinical injury group, where a child, maybe the child had a traumatic brain injury or a birth injury to the brain when the child was born. And what they found was there were changes in neural connectivity, alterations in neural activation, and also increased cortical thickness. There was another paper in 2011 which also showed that there was focal increase in the prefrontal cortex areas when they looked at the brain by its structure itself in the grey matter volume after the children were trained for a particular period of time. So this is the last study which I want to talk about before I wind up. This was a paper which was published by the Department of Psychiatry of AIIMS and in collaboration with UCSF. So they designed something called as an online neuroplasticity targeted remediation of attention deficits in children. So this was a small randomized trial which they conducted, which was published in 2016, where they used novel neuroplasticity-based training program and help children, like I said, to reduce the signal noise ratio. So what is the signal noise ratio is basically a principle which follows that they have trained children to decrease distractions, suppress the distraction and improve their focus and attention. So there were 7 steps in the app, in the software which they used, and what they found was after a period of 12 months, children who were trained using this on-track software definitely were doing clinically better. So neuroplasticity overall can help in therapy success, and by that I would want to go back to those rules which I talked about, where we are looking at how we use techniques of neuroplasticity to in turn help families understand what is exactly necessary for their children. Many times when I see children in the clinic, parents tend to say, we have been giving this particular medication for 2 months, 6 months, 1 year, but we are not really we are not seeing clinical improvement in the child. But probably they were not really advised appropriately about how experience training and behavioral intervention, even if it is going on at the home level itself, can be a very important factor. So what I tend to say is that it should go hand in hand, the pharmacological and the behavioral management, because definitely pharmacology is not really recommended long term unless the child moves into adulthood to have a very severe problem, or the child is having other serious comorbid issues because of which pharmacology is mandated. So some of the future directions in this field as of now, I think in the past couple of years, people have looked at how epigenetics is influencing neuroplasticity in individuals with ADHD, where they are saying that microRNAs can have implications in post-transcriptional regulation. There are also newer neuroimaging studies which are coming up, where they are using techniques of AI and machine learning to look at how cognition analysis, when applied to a functional imaging data or a structural imaging data, can make predictions, can help in the diagnostic status, and like how we are aware that some of the neurodevelopmental disorders have subtypes. It's not just one blanket term. We can identify homogeneous subtypes of categories. Maybe a technology in the future can help us do that, so that we can use technology not only for intervention but also for early detection and help us predict what kind of path that particular child or an adolescent will take. Of course, in the technology end, I'm sure many of you are aware of these apps which are available. I just listed the 4 most widely popular apps which are popular for in the adults with ADHD category, especially, where you can use your mobile phone, download the app and train your brain to focus in a better way. So thank you very much for your kind attention.